Good evening, everyone. Welcome to the Higgs Journal Club for the month of December. This is the last one this year. And today we have our mentor, Dr. Jose Chaco sir, Higgs directors, Dr. Gansham sir, Dr. Srinivas sir. And to take us through the journal today, we have Dr. Rohan Parekh from Mumbai and his guide, Dr. Ketan Kargirwar, also from Mumbai. Today, we're going to speak about inhaled amikacin to prevent ventilator-associated pneumonia. Over to you, Rohan.
Thank you, Dr. Navina. Good evening, everyone, and thank you for this wonderful opportunity to present this trial and in this journal club. So today my topic is the trial which was done in New England Journal of Medicine, which was published in NEJM, inhaled amikacin to prevent ventilator-associated pneumonia. So the background, hello. So the VAP is the most frequent presentation of hospital-acquired infection of the lower respiratory tract. It is the leading nosocomial infection worldwide. The estimated incidence varies depending on the definition, screening methods, and patient populations, from 2 to 30 episodes per 1,000 days of mechanical ventilation. Disease develops in 5 to 40% of intubated critically ill patients. Attributable mortality of up to 13% and contributes to increased systemic antibiotic consumption, duration of mechanical ventilation, and ICU length of stay. So the previous research which was done, it has identified a potential therapeutic window to prevent the progression of VAP, which typically peaks after 7 days of ventilation. Various preventive strategies such as reduced sedation, weaning protocols, patient positioning, tracheal tube cuff management, and oral care have been implemented, but have not sufficiently reduced the burden of VAP. VAP arises mainly due to microaspirations around the tracheal tube cuff and the formation of biofilm, leading to bacterial spread in the tracheobronchial tree. Appearance of MDR pathogens is why there has been a resurgence of interest in nebulized antibiotics in recent years. With the exception of colistin, there are no experimental data that support the idea of nebulized antibiotics that reduce systemic toxicity. Data exists only for clinical cure and no conclusive evidence on microbiological cure or mortality benefit. So this trial, the inhaled trial, which was done in the past, which is a double-blind, randomized, placebo-controlled superiority trial. And in its conclusions, the findings did not support the use of inhaled amikacin, adjunctive to standard of care IV therapy in mechanically ventilated patients with gram-negative pneumonia. So this is the basic pathophysiology of how a nebulized antibiotics works. In the left side, you can see where if we use a IV antibiotic therapy, it generally, the diffusion to the lung is limited and it results in concentrations that may not exceed the MIC, which can eventually lead to treatment failure. But on the right-hand side, you can see a nebulized delivery in the blue panel, which is the concentrations achieved are well above the MIC, and thus resulting in improved efficacy of concentration-dependent antibiotics. And even the difficult to treat pathogens like MDR and XDR bugs, which is treated successfully. So the hypothesis is a 3-day course of inhaled amikacin, which is initiated after 3 days of mechanical ventilation, might reduce the incidence of VAP. So it has this article has proven benefit if inhaled amikacin is used in the early stages, which is after 72 hours of intubation and no later than 96 hours. Although it has not validated, although it has not been validated to see the effectiveness in patients who are already infected with VAP. So the study design consists of a multi-center, double-blind, randomized control. So the study design consists of a multi-center, double-blind, randomized controlled superiority trial, which is conducted across 19 ICUs in France through a trial period of 2017 to 2021. The population, the inclusion criteria is the patients who have undergone invasive ventilation for at least 72 hours and age more than 18 years. Exclusion criteria will be the patients who are invasively ventilated for more than 96 hours, suspected or confirmed VAP, severe AKI without RRT, or if the patient has CKD, extubation scheduled within 24 hours, and if the patient is receiving systemic aminoglycoside therapy. So the intervention which was done is amikacin was nebulized with a vibrating mesh nebulizer with a dose of 20 milligrams per kg of idle body weight. And on the comparator, the placebo, 0.9% normal saline with identical administration regimen. So nebulizer were administered once daily for 3 consecutive days using a vibrating mesh nebulizer. The nebulizer was placed upstream in the inspiratory limb of the ventilator, and different ventilator circuits were used with or without active humidification according to the preference of the attending physician. The ventilator settings, sedation, muscle relaxation were at the discretion of the attending physician. However, general guidance on aerosol delivery was provided to all the investigators. And all centers adhered to the international guidelines for VAP prevention. So as you can see in this figure, there was an opaque nebulizer used through which the drug supply with the opaque tubing as well. So the study is conducted in a blinded manner throughout. The patients were randomized in a 1:1 ratio who receive inhaled amikacin or inhaled placebo, with stratification according to the trial center and administration of systemic antibiotics on the day of randomization. Although also allocation concealment and block size with blocks of 4 patients, which was generated by a statistician who was not otherwise involved in the trial, was also ensured by a centralized secured online server and were not disclosed to patients or persons involved in patient care. So the primary outcome which they have studied is first episode of VAP from a randomization to day 28. The diagnostic standards which were used, the standardized workup for VAP across centers in line with the international guidelines, which required a positive quantitative bacterial culture in a pulmonary sample, and at least 2 of the following findings, which consist of hyperleukocytosis, leukopenia, fever, or purine secretions with a new infiltrate on chest radiograph. The key secondary outcomes, incidence density, the incidence of ventilator-associated pneumonia due to gram-negative bacteria with in vitro susceptibility to amikacin, the ventilator-associated events comprising ventilator-associated conditions, which consisted of worsening oxygenation over 2 days after a stable or improvement period, infection-related ventilator-associated complications, and possible VAP. So the methodology they followed is they used intention to treat principle. Cumulative incidence curves were used to represent the timing of randomization to the first episode of VAP. Due to the non-fulfillment of proportional hazards assumption, a restricted mean survival time analysis was adopted, considering death and extubation as competing events. For time to event analysis, a hazard ratio was computed from the total group populations with the use of fine and gray regression model. Statistical analysis for secondary outcomes were not adjusted for multiplicity, and therefore secondary outcomes finding should be interpreted as only exploratory. The incidence expectation, the expected incidence of VAP was 6% in the amikacin group and 12% in the placebo group. To achieve 80% of the power with a 2-sided alpha level of 0.05, the calculated sample size was 850 patients. So a total of 50,605 patients were screened. And so a total of 50,600 patients were admitted, and out of which 6,419 underwent ventilation, more than 48 hours, in which 5,569 were not enrolled because of all the exclusion criteria involved. So a total of 850 underwent randomization, and they were divided into 2 groups. 420 received inhaled amikacin, 430 were assigned to receive inhaled placebo. In the final intention to treat analysis in both groups, 417 were included for the amikacin group and 430 were included in the placebo group. So these are the characteristics. It is all divided. It is all divided in classical age, sex, body mass index, the type of admission. The outcomes which were studied, the primary outcome and secondary outcomes. The primary outcome is a first WAP episode from randomization to day 28. Now, as you can see, the p-value is significant in this group. And for the amikacin group, it was 62 patients, and the placebo, it was 95. Although all the secondary outcomes, which was not really statistically significant, the duration of invasive ventilation days for mechanical ventilation was the same in the amikacin and placebo groups, marked as 9 and 9.
Dr. Srijit and Dr. Mukesh, can you please go on mute? Dr. Mukesh, Dr. Srijit.
Okay, sir.
Dr. Mukesh, can you please
Yes, sir,
mute
please.
yourself?
Yes, 1 minute, sir, please.
So this is the primary outcome, which is described in a Kaplan-Meier curve. It is showing a restricted mean survival time of 1.5 days. So this is a primary outcome, ventilator-associated pneumonia, where inhaled amikacin is proven to be beneficial. And the secondary outcomes were ventilator-associated complications or infection-related ventilator-associated complications, and possible WAP. So possible WAP is the only graph which has shown a significant treatment difference. So the strengths of the study are that it is demonstrated that a 3-day course of amikacin significantly reduced the incidence of WAP by day 28 compared to placebo. The safety profile, less than 2% of the patients experienced significant side effects, and a robust methodology, including a double-blind placebo-controlled design, robust assessment of the primary outcome as well. So it has a potential for early intervention. There may be merit in evaluating interventions
while approving, right?
Prior to the 3rd day of ventilation, balancing the risk of increasing antibiotic resistance. The trial limitations are that trial was not powered to investigate other patient-centered outcomes, such as mortality or length of stay in the ICU.
Dr. Pragna, can you please go on mute?
So the trial limitations, as I was saying, it was not powered to investigate other patient-centered outcomes, such as mortality or length of stay in the ICU and hospital. Systemic antibiotic use, so it is not designed to assess the impact on systemic antibiotics usage, which is a critical aspect in the context of antibiotic resistance. And finally, to conclude, in this large RCT, a 3-day course of amikacin reduced the burden of WAP by day 28 as compared with placebo, with a generally favorable safety profile. However, a broader patient-centered outcomes and the long-term impact on antibiotic resistance require further investigation. Thank you, sir.
Thank you.
Yeah, thank you, Dr. Rohan. We'll take the comments from Dr. Ketan Kargirwar.
Yeah, thank you, Mobina. I think Rohan summarized this trial. This is one of the dilemma in terms of inhaled antibiotics. We have been using inhaled antibiotics for quite a
Ketan, we can't hear you.
Hello.
Yeah.
Can you hear me now?
That's better.
Yes.
Yeah. So inhaled antibiotics has been being used for quite long time, but there has been a lot of dilemma in the clinical practice whether they are clinically efficacious or not. And several trials which has come across, not only including amikacin, but other antibiotics like colistins and other aminoglycosides, there have been variable results. About this trial, especially a few things. First, about the methodology being quite robust, as you have described. They have covered all the important aspects. They have tried to involve basically a clinical question whether we can prevent prophylactically using inhaled antibiotics, WAP. Now, WAP is a major burden in our day-to-day critical care practice. It has a significantly associated with higher mortality. Now, basically using prophylactic inhaled antibiotic using amikacin has shown any benefit is the main hypothesis of this trial. And what it has shown right now is though it reduces the incidence of WAP, but main secondary outcome which drives our care is the length of stay, the length of ventilation days has not been shown any difference. So putting this trial in the inputs of this trial, the findings of this trial in a day-to-day practice is a bit difficult because as it has not shown to reduce any ventilator days, it has not shown to change any secondary outcomes, length of stay, hospitals. But yes, it has shown to reduce the VAP rates. Now I have a question here for in my mind that whether how to differentiate whether this is a actual VAP infection or it is a colonized. That is one from this trial. Second, should we change our practice or not? Should we start using amikacin in patients who are on ventilators whom you think are going to get ventilated for more than 96 hours to prevent the amikacin, to prevent the VAP? So I would ask Dr. Jose if what would he like to say on this?
Yes, Ketan, I agree with most of what you mentioned. The diagnosis of VAP was based on the standard criteria, although there are several pitfalls, as we know, with these criteria. A lot of it is subjective. Like, for instance, the X-ray infiltrate, which could mean VAP, or it could mean collapse, or it could mean other infiltrates which are non-infective in nature. So that's a potential problem with this diagnosis. The degree of virulence of secretions, again, is subjective and might vary from observer to observer. And then, of course, the other two criteria, white cell count, as well as the presence of fever. Fever could be due to other causes as well, including non-infective causes. So that being a little bit unclear, one would have hoped that the authors would look at more patient-centered outcomes, which really matter. Like, for instance, mortality or the duration of mechanical ventilation, which you would expect to be prolonged with if there is ventilator-associated pneumonia compared to a patient who does not get affected with ventilator-associated pneumonia. But they did not include these as the primary outcome. These were secondary outcomes, and the study was not powered to address these. But if you look at just the numbers, you will find that the ventilation days are almost identical, median of 9 days in both groups. And the interquartile range is also almost identical, 6 to 15. So how do you explain this? If in fact the use of amikacin did in fact reduce VAP, and if you do expect VAP to have a clinical impact as in reducing the number of ventilator days, how would you explain an identical number on both arms, although the study was not powered? Same with mortality as well, 24% versus 26%. And ICU days, again, very similar in both groups. So that's a little bit hard to explain. If in fact this particular intervention did result in a reduction of ventilator-associated pneumonia, it does not seem to have impacted meaningful patient-centered clinical outcomes. Then, of course, one needs to consider the fact that up to 78% patients in both groups were already on antibiotics anyway. By the time they started getting this strategy, and you would expect, depending on what type of antibiotic they were on, the use of amikacin may or may not really have mattered. And the authors do not provide us details about the type of antibiotics that these patients were on to begin with. And the third point that I would like to raise is they mention about cost effectiveness, but no cost analysis was done, which again would have been meaningful in this particular setting. So overall, I would only suggest that this trial may generate a hypothesis that the use of amikacin may reduce the incidence of VAP, but you need more robust studies to really show that it impacts meaningful clinical outcomes. After all, that's what we are worried about. We are not particularly worried about whether a patient fits into the definition of VAP or not. That's my initial thoughts.
Would you change your practice, sir, with this?
I wouldn't. My practice currently is not to use inhaled antibiotics as prophylaxis, certainly. We occasionally use colistin as treatment, not as prophylaxis. So my practice remains the same. I wouldn't start using amikacin, in other words.
Ketan or Parik, Rohan, just a small doubt. Did they use bronchoscopy bowel cultures in this trial for diagnosing VAP, or did they use ET cultures?
No, they don't mention about bronchoscopy. It's all brachial aspirate, I would assume.
Because that could also be one of the factors. For example, if you're giving inhaled amikacin and you're taking upper airway secretions, there is a high probability you may get cultures negative.
That is potentially possible, yes. It might sterilize the secretions from the upper airways.
No, sir.
Rohan, we can't hear you.
Sir, can you hear me now?
Yeah.
Yes.
So, sir, in the supplementary appendix, they've mentioned that they've taken the BAL or the mini BAL cultures to prove a culture-proven VAP while diagnosing. But none of it is mentioned in the article as such.
So they would have done on a few patients, isn't it? It wouldn't have been standard practice. It's not realistic anyway to do bronchoscopy
Yes,
and to diagnose VAP. Not realistic, really.
Using 0.9% saline, can that be instead of not using anything versus amikacin? Would it make a difference, sir?
I think the authors mentioned this as a limitation as well, because the instillation of saline itself might lead to the likelihood of infection and positive cultures.
Yes.
Gansham, sir, what is your take on this trial?
I think both Ketan and Dr. Jose have mentioned almost all the different aspects. I think another important point is in the control group, the rate of VAP that they have mentioned is 22%, which I think is pretty high, right? Most of the centers today don't report that high of a VAP rate. So if at all your own institute has a lesser VAP rate, then I think the number needed to treat to decrease the incidence of VAP with this intervention would be significantly higher. That is one thing that we just need to keep in mind. 22% is still a high VAP rate for any institute. So that is something that we need to keep in mind. I totally agree with sir. Both the duration of mechanical ventilation or the mortality was pretty much the same. So I'm not sure, but I agree with sir. Even I have never used inhaled antibiotics. I think the ECMID guidelines recommend against the use of inhaled antibiotics, but the IDSA guidelines recommend that if you are dealing with a XDR bug, then it can be used as an adjunct to IV antibiotics.
Okay. Srinivas sir, your comments on this?
Sir, Jose sir, you're still muted.
Yes, Raman, yes. One of the other things I wanted to point out is they looked at the first incidence of VAP in 28 days. So we all know that VAP is a problem in long-term ventilated patients, many of whom get ventilated for longer than 28 days. And these patients are particularly prone to VAP. So maybe the use of amikacin between 3 to 4 days, that's what they did, between 72 to 96 hours. That might prevent short-term infective complications, but it may not have a significant impact on longer-term complications, and hence may not affect mortality. That could be one of the reasons why they couldn't show a difference in mortality anyway. The second question is, how much is the attributable mortality of VAP? In fact, there were some studies from several years ago that suggested that there is very little attributable mortality to VAP. But I think recent studies say there is a attributable mortality of about 10%. So this study was not adequately powered to look at that. And of course, the future lies in trying to formulate a study that looks at mortality and the duration of ventilation, which should be the main endpoints.
Thank you, sir. Srinivas sir, your comments on this?
On this study?
Yes.
Look, aminoglycosides inhalation is not the first time that somebody has tried to give aminoglycosides as an inhalation agent. Tobramycin has been used for quite some time. Late 90s onwards, tobramycin has been recommended as a nebulized delivery for patients with cystic fibrosis. But that's a specific, very niche cohort of patients. But coming to an intensive care unit and giving an aminoglycoside by nebulization or inhalation, expecting it to reduce the incidence of VAP is a good concept. But as Sir said, the hard surrogate, the hard outcomes like ICU days, length of stay, ventilator days, tracheostomy rates, they have to be compared. And we don't have information. We don't have solid proof that it actually improves the hard outcomes. Now, when you look at infection control data and infection control epidemiological data, one of the other surrogate markers of your VAP rates or your infection rates, be it LAPC, COTI, nosocomial sinusitis, your antibiotic utilization. If they had actually compared the high-end antibiotic utilization pre and post implementation of this protocol, if the antibiotic utilization had reduced post the use of prophylactic inhalational amikacin, then we could probably have some economic justification as a cost-effective method of reducing the incidence of VAP. We don't have that data either from the study. So, although it's a well-designed study, it doesn't prove much, except for the fact that current cons previously we thought that if you take a tracheal secretion and it shows only not the bowel, and there are no infiltrates, your lung compliance is good, and your FiO2s are not increased, then you don't need to treat it. Now that paradigm has shifted, and people now believe that if you have a drug-resistant bug causing tracheobronchitis, you still have to treat it. So if against that background, this may reduce the incidence of tracheobronchitis. That is what I'm willing to accept, but that's again a hypothesis which is to be tested in a subsequent RCT. So will this change my practice? No. Does it improve hard outcomes? No. Will it improve soft outcomes? We don't know.
I was just wondering why only amikacin was chosen to be used for this trial. So are there any other potential antibiotics that can be used for this purpose?
So as Sir has said, as I've said, tobramycin was used for almost 25 years now. As Sir has said, colistin is still used for treatment, not for prophylaxis. So there are a few antibiotics which have there. There are people who have used ceftazidime for Pseudomonas colonization in bronchiectatic patients, but uh, this is the aminoglycosides have a very good penetration potential across mucous membrane. So that's probably the reason why you tend to use aminoglycosides and polymyxins rather than propenem, sulfaperazole, tazobactam, the beta-lactam antibiotics when it comes to transmucosal administration. That's probably the reason why it was used.
Just to add to that, Navina, I think people have also used astronam. Some of the studies have suggested they've used astronam, especially in patients on a background of bronchiectasis, cystic fibrosis, where they try to look at decreasing the load or eradicating Pseudomonas.
Any specific properties of antibiotics that we look into, sir, when we think of using them as inhaled antibiotics rather than the IV?
I think for me, probably one of the most important aspects would be one, whether it's susceptible to that, whether the organism is susceptible to the antibiotic or not. Second, do you have a nebulized form? I think most of the times we try to kind of use the IV formulations, but there is a potential for side effects, especially bronchospasm or initiating a cough or hemoptysis or hypoxemia. So if you have an antibiotic which is in the nebulized formulation, I think that would be an ideal agent to be used.
So as inhaled amikacin is not really available with us right now, so can we do this kind of a thing, something like this with the nebulized colistin?
Colistin, as I mentioned, we have been using the same
for tracheobronchitis treatment, but what about the prevention of VAP, sir?
I think if you use something like colistin as first-line preventive antibiotic, that might actually invite the development of resistant organisms. That's a major concern. I think the authors use amikacin because they were aiming primarily at gram-negative organisms first. And secondly, as Srinivas mentioned, amikacin does not penetrate into the lung if given systemically, but it has reasonably good effect when administered as a nebulizer. So we don't have nebulized preparations either. Whenever we have used inhalation, it has been the same as the intravenous preparation, but we have the aerogen nebulizers, the vibrating mesh nebulizers, which may be quite effective when used on the inspiratory limb.
Using different kind of nebulizers, will it make any difference, sir? Like from one nebulizer to the other?
Yeah, the theoretical advantage is the particle size is very, very tiny, much, much smaller than if you use a conventional gas-driven nebulizer. And these particles are expected to penetrate much better, deposit much more distally, and be more efficacious. That's at least the theoretical rationale behind it. So then, in fact, that's what they recommend for nebulized antibiotics, the vibrating mesh nebulizers.
Do you use that for the colistin nebulization, sir, for tracheobronchitis?
Yes, on the few occasions that we used it, we did use those nebulizers. We do have them with us.
How do you differentiate it if it's from VAP or tracheobronchitis?
Ketan want to add something?
Ketan, sir?
Yeah. So just wanted to add to the one important question.
Your voice is
low. Can you hear me now?
Yes.
Hello. Yeah. So two things to add up to your basic question is what properties a drug should have. So this is the most important thing. The drug which comes in IV formulation must not be used for inhalation formulation. There should be a specific properties of the drug, and properties like when we commonly use drugs which are systemically used, the certain pharmacokinetic properties like the binding and the lipophilic or hydrophobic nature and the permeability is more important while considering the inhalational agents. So now bacteria are mostly charged particles, and drugs should go and act on them. They should have an opposite forces to attract each other. So drugs get attached to the colonized bacteria. So that's the different mechanism when you use inhaled antibiotics. So inhaled antibiotics should be mostly a lipophilic in nature, have a negative charge, so they get more deposited in the alveolar level. Now, if you see the anatomy, there are different generations of trachea, lungs, bronchial, and alveolar sac. So drug need to be deposited, and that job, if we have to do, the delivery, it's not the molecule which is important pharmacokinetically, but also the mechanism of delivery, like as sir was saying, the type of nebulizer which can deliver the drug at right place to act on it. So previous trial, this or in our day-to-day practice, this is the uh, uh, most neglected part, that how the drug is being actually delivered, which limb of the ventilator circuit. Like in this trial, they have categorically explained that inspiratory limb, they have put the jet nebulizer. So if you deliver the drug in an appropriate way, while patient is on a mechanical ventilation, or if the patient is not on a mechanical ventilation, using a specific delivery devices, you might get the result. Now, to share that is one about the pharmacokinetics and pharmacodynamics, what we should be having. And of course, the size of the drug particles also matters, as sir was saying, to reach the barrier. It should be between 1 to 5 micron. But having said that, in our practical, got a few experience of few special category of patients where we use left, right, center inhaled antibiotics like colistin and tobramycin sometimes. And because we are those group of patients are lung transplant patients, where they are either colonized or they have actual bug. So in these patients, we do use prophylactic inhaled antibiotics, and uh, we monitor them, and we frequently have to do the bronchs to get the surveillance cultures. So we can trend actually the effect of inhaled antibiotic along with systemic antibiotics. But in the short, whatever studies are there, it has inhaled antibiotics has kept the bacteria are still colonized, so it has not completely eradicated. But yes, the incidence of VAP has been little less when we have used colonized inhaled antibiotics, because we are doing the cultures. So if you have what I wanted to give a message, if you are using an inhaled antibiotic, then you have to monitor it by either by repeated test or bronchoscopy and see the result. Either it would be a surveillance cultures or it would be a diagnostic cultures. That is what we have to keep in mind. It's not like totally contraindicated. If I am using a drug which needs a drug monitoring level, then I can basically understand its effect, what is it is helping or not helping objectively.
How frequently do you go for the BAL, sir, to monitor?
So it depends on the condition. One is if clinically some new changes are there, like clinical in this setting, usual what criteria are new infiltrates, new oxygen requirement, then or a surveillance files are done on the basis of weekly bronchs. There's a weekly bronchs.
Okay, thank you, sir. So one question from my side, like when you have a positive culture from the ET or the tracheal TT secretions, whatever, when do you think that it's only tracheobronchitis and you only want to give inhaled antibiotics, not along with the IV antibiotics?
This is for me.
For anyone.
Yeah. So of course, I first look into the clinical condition of the patient, whether the patient is having signs of new onset fevers, new infiltrates, or there is change in the color and consistency of the secretions, or there is any clinical deterioration. or the last is whether my source for which this antibiotics was started is not under control. So these are the things I would take into consideration and treat it seriously. If my patient is improving, the oxygen requirements are fine, clinically much better. Though laboratory-wise, suppose I have elevated counts, but my patient is occupied, so with no change in oxygen requirement, I will not treat. I will just treat it like a bronchitis and colonize uh, uh, in my day-to-day practice.
With only inhaled, no IV antibiotics.
So I have not used inhaled antibiotics alone. So they are not using inhaled antibiotics alone at any time. It is always with systemic antibiotics.
Joe, sir, if you think it's only tracheobronchitis, would you treat them with IV plus inhaled or only inhaled?
No, generally speaking, tracheobronchitis, if I know very well that it is just colonization and just proximal airway infection, generally speaking, I look at the holistic picture, of course, and if the patient is doing well otherwise, like being weaned or weanable, the ventilator support is coming down, oxygenation is not deteriorating or improving. And if these conditions satisfy me, I wouldn't be bothered. I wouldn't use antibiotics in any case. Only if they deteriorate clinically or if they fail to improve as expected, would I consider treating them with antibiotics. So I wouldn't just go by cultures alone.
Any comments, sir? Gansham, sir?
Naveen, I don't have much experience with inhaled antibiotics. I have not used it till date, maybe one or twice, but generally, I have not used it. If in doubt, I've always gone with IV antibiotics.
Srinivas, sir?
Well, Navina, now you have to look at it in two ways. One, sometimes you get a culture report which suggests an antibiotic which does not have systemic penetration into the pulmonary tissue, like an aminoglycoside. In such situation, maybe if you want to use the other characteristics of transmucosal spread of these drugs, maybe you are right. You can use this as a supplement to systemic therapy. You may use some other antibiotic which can work synergistically with um, uh, this method of delivery. The other aspect of it is, as I've said before, now tracheobronchitis is considered as one of the causes of fever in an intensive care patient. Previously, we used to say it is COTI, phlebitis, bed sore, DVT, sinusitis. Tracheobronchitis has been added to that list at this point of time. So, if your lung compliance is good, if it's not a ventilator-associated infective condition, then if though there is no other source of infection and tracheobronchial aspirate cultures repeatedly are showing an organism which is susceptible to antibiotics which can be delivered by a nebulized route, you can save the patient from the systemic toxicity of some antibiotics by giving the nebulized antibiotics. So that's the perspective at this point of time. But that's a pure pharmacological and logistic perspective. Clinically, at the bedside, we haven't been able to show a hard benefit with this strategy for treating these kind of infections.
Okay, thank you, sir. Your closing comments on this, sir?
Mine?
Yes.
Good paper to read. Good analysis for somebody learning to read a paper, but it will not change my practice.
Closing remarks, Joe, sir?
Yes, the strengths of the study, of course, we have pointed out the limitations. It's a multi-centric study across France. It was blinded, so you need to give credit to the authors for taking the pains to blind the study. Multi-centric, it was stratified by center, and they used a uniform VAP preventive strategy across all the units. they analyzed almost all their patients. There were just some 3 or 4 dropouts. So that all these add strength to the study, although it did not finally boil down to improve patient-centered outcomes. It did show that there is a potential that it might do so, that it might reduce the incidence of infection. It at least generates a hypothesis that it might improve clinical outcomes, but then we have to consider a sufficiently adequately large sample size specifically to look at important patient-centered outcomes, including ventilation days, hospital stay, ICU stay, and mortality. So these are the things that really matter. This is generation of hypothesis. We need to follow it up with a proper patient-centered outcome study.
Thank you, sir. Gansham, sir, any closing remarks?
See, the kind of dilemma that we are facing with respect to the increased incidence of VAP or infections with MDR and XDR bugs, I think the inhaled delivery opens up a new approach, or especially in situations where you have an XDR bug, you don't have many antibiotics. And as Srinivas said, suppose the patient is, the infection is susceptible to aminoglycosides, and we know that they don't have a very good penetration to the lung. I think in certain special situations, this definitely opens up the avenue by which you can have, apart from your systemic antibiotics, inhaled delivery in selected patients. As a routine, probably not, but in selected patients, I think yes.
Thank you, sir. Thank you, Dr. Ketan, sir. Thank you, Dr. Rohan. Thank you, Jose, sir. Thank you, Gansham, sir. Thank you, Srinivas, sir. Wishing you all a very happy New Year 2024. We'll see you all in the next year. Do subscribe to the YouTube channel for the Hicks. Thank you all.
Thank you. Thanks a lot. Happy New
Thank
Year
you,
to all.
Navina.
Thank you.
Bye-bye, all of you. Thank you for joining.
Thank you, Navina, and wish you all a great 2024.
Same to you, sir.
You too, sir.
Bye-bye. Thank you.
Bye,
Bye,
Ketan.
Ketan.
Thanks, Rohan.
Thank you, sir.
Best wishes for your exam.
Well presented, Rohan. Well presented. Well done.
Thank you, sir.
Thanks.
Bye, Ketan.
Bye-bye, sir. Thank you, Navina.